Thursday as well. But we need to change volume. That's Boyle's law. That the relationship, there's an inverse relationship between volume and pressure. All right? So what were the muscles that we used to increase the distance between the front and the back of the thoracic cavity?
External intercostals.
All right, external intercostals.
Diaphragm.
And diaphragm creates the distance between top and bottom. So what are the nerves that innervate the external intercostals? Intercostal nerves. What level of the spinal cord would these intercostal nerves be associated with? We talk about damage to the spinal cord and not being able to breathe. So intercostal nerves are the only nerves that don't form a plexus. If you remember from Bio430, the cervical plexus, and brachial plexus, lumbar, and sacral plexi. Intercostal nerves are the ventral rami of the spinal cord, is spinal nerves coming out of the spinal cord. They don't interweave with anything else. They actually start with T2, because the first thoracic spinal nerve is actually joining the nerves that go into the upper lip. It's part of the brachial plexus. So they start with T2 and go to T12. Okay? So that's kind of far down. All right? If you have damage at the cervical, you break your neck at, say, C7, you would still have activation, innervation through the phrenic nerve, which is C3 through 5. So you wouldn't have, if you break the neck, your neck at C7, you wouldn't have the phrenic nerve, you wouldn't have the diaphragm, but you would still have the intercostals. The diaphragm probably makes more of a change in thoracic pressure than the intercostals do. Okay? But you would have at least some of those muscles. Now remember we said for accessory inspiration, we use the scalenes. Those come off the cervical vertebra and attach to the first rib and the clavicle. And the other muscles we use have their origin and insertion reversed. So if they have an attachment, their origin is normally on the ribs or the sternum. And we stabilize the head, say for sternocleidomastoid, and not allow it to be flexed or extended, then we can use sternocleidomastoid to lift up the sternum and clavicle. And if we stabilize the scapula, fixate it, remember that term, then the pectoralis minor, shown right here, will not pull the scapula forward, but the scapula won't move, and so the ribs will be aided in being elevated. So we reviewed this on Friday, just putting a little bit up here again. So pectoralis minor, serratus anterior, not all of serratus anterior, but some of those fibers will work, and sternocleidomastoid. Why not pectoralis major? All right, insertion is the arm, but why can we just stabilize the arm and not let the arm move? Remember, the orientation of major fibers are too horizontal. So they're going across the chest in this position, a little bit down from clavicle, but not very far, and mostly horizontal, so there's not sufficient, you'd have to be really struggling to pull in the pectoralis major. All right, for expiration, for normal expiration, remember this is a passive process. So it's just relaxation of inspiratory muscles. And we see this in the pattern of breathing. So inspiration usually takes about 2 seconds and then about 3 seconds to expire for expiration. Because it's just the passive relaxation. And then 2 seconds and 3 seconds, 2 seconds and 3 seconds. Same volume out, all right, as in, but it takes a little bit longer for that to move out. And then when we do active expiration, using muscles that assist the relaxation, so pushing the diaphragm up farther than it would move up just as normal relaxation. We use our anterior abdominal muscles, flexural rectus abdominis, and to assist pulling the ribs downward, we use the internal intercostals. So the purpose with all of this is to change the volume, increasing top to bottom or front to back. So as we increase that spacing, we see, I'll come back to that in a moment, we see a change. So here's what I was diagramming on the board on Friday. So if this is our volume at rest, then when we inspire, we increase anterior, posterior, superior diameter, same number of gas particles, so they exert a lower force. There's on the overall walls, and pressure decreases. Okay, we decrease the volume, same number of gas particles, still moving around, a greater force is going to be measured. So this is actually illustrated in this little animation here. So volume is high, pressure is high. When volume is high, pressure is low. When volume is low, pressure is high. Okay, and it just has to do with the number of particles in the volume. So we start out with inspiration. Atmospheric pressure. What do we mean by atmospheric pressure? We'll refer to it more on Thursday. But what do we actually mean by, how do we measure a gas pressure? Why does gas have a pressure? Why does it have a force, a mass? Does it have mass? Yes. All you have to do is just, so it's very windy outside, all right? So with the wind blowing, you're feeling molecules of gas against your body. All you have to do is take your hand and just move it through, and you can feel some resistance. If it was in a vacuum, you wouldn't feel that, all right? What you're feeling, what your hand is compressing oxygen, nitrogen primarily, and smaller amounts of carbon dioxide and other gases. So if we were to take a pan of mercury and place in that a tube that has no air in it, so it's at a vacuum, gravitational force is going to pull those molecules of gas, be it carbon dioxide or nitrogen or oxygen, onto the surface of this pan. Okay? And as they push down on that, bouncing down, they're going to push the mercury level up. And at sea level, there's enough force of those descending, bouncing gas molecules to push the mercury to a level of 760 millimeters. All right? So when we talk about atmospheric pressure at sea level, we say 760 millimeters of mercury. And it's kind of the essence of what we're talking about. If we were to take this same pan up to a higher altitude, farther away from the center of the Earth, there would be fewer gas molecules, all right, and this number would decrease, and the force would be less. So that helps to give you a visualization of what we're talking about when we talk about the gas pressure. So we're measuring the force created by the gravitational pull and the mass, the actual molecular mass of these gas particles when they push down on that mercury surface. So the more gas particles they are, the more force is created. So when we talk about our diagram here, we have our conducting airway, which is open to the atmosphere through your nasal or oral cavities. And atmospheric pressure at sea level, that indicated over here, is equal to 760 millimeters of mercury. Then we have the airways passing into the alveoli. So at rest, without any changes in the thoracic volume, intraalveolar pressure is also, so at rest, equilibrium. Well, equilibrium exists at different stages. So at rest, neither breathing in nor breathing out, intraalveolar pressure is going to be equal to atmospheric pressure. And air will not move into or out of the lungs. So that's what happens when you're just not taking a breath. Now I had you do that with your mouth open, but your nasal cavity being open is going to be the same way. So air is neither moving in nor moving out. All right? So when you take air in and you lower the diaphragm and you elevate the ribs slightly, we're not changing atmospheric pressure, but we're lowering intraalveolar pressure. Okay? And it will drop. So with inspiration, intraalveolar pressure can drop to about, usually it only moves about 2 or 3 millimeters. So we'll put it down here at about 758 millimeters of mercury. It can go a little bit lower with deeper breaths. So now atmospheric pressure at 760 is greater than intraalveolar pressure. So remember, airflow is due to a gradient. It goes from high pressure to low pressure. That's why we have the windy day outside, because we're at lower pressure than wherever the wind is coming from and the air is flowing. And so we have this relationship so that with inspiration, atmospheric pressure is greater than intraalveolar pressure. With expiration, the diaphragm moves up, the ribs move down, the thoracic volume becomes lower, and intraalveolar pressure becomes higher. And the air moves out of the lungs. It's as simple as that. It's a pressure gradient. So the diaphragm relaxes, moves up, pressure around the lungs increases, and pushes air out of the lungs. So that can be illustrated by this little lung model here. The ribs that are not mobile in this model, but they would be represented by the diaphragm. Okay. And the trachea is this straight tube through there, 2 bronchi, and the balloons represent the alveoli and the lung volume. The large space around the lungs is going to represent the space between visceral pleura and parietal pleura. Okay? Quite large in this situation. So our diaphragm will move. Now notice that as I lower the diaphragm, air is filling the balloons or the lungs. So by creating a larger volume around the lungs, I've decreased the space. That's a closed container now that space is in. And so the space, the pressure around the balloons is lower than the pressure out here, and air is pushed into the balloons. Now when I relax the diaphragm and push up, all right, pressure around the balloons increases and collapses them and pushes the air out. And so that's the basic aspect of pulmonary ventilation. We have an additional source of pressure though, and that is in the intrapleural space. So let me make this a little bit more realistic here. And I'll attach the pleura. So we have visceral pleura. And parietal pleura attached to the chest wall and to the diaphragm. And intrapleural pressure is always less than intraalveolar and less than atmospheric. Even when intraalveolar pressure is greater than atmospheric, intraalveolar pressure never becomes greater. All right? So intrapleural pressure is about 4 millimeters of mercury less than intraalveolar. So if we look at this graph here, it's hard to see the line, but this line right here is showing intraalveolar pressure. Atmospheric pressure is not going to change. I don't move up to 10,000 feet with every inspiration and move back down to sea level with every expiration. All right, so atmospheric pressure is going to stay the same. So the 0 here is really our 760 if we're at sea level. And then intraalveolar pressure when we breathe in is going to be lower than atmospheric pressure. So it's dropping here to about 758, 759. And atmospheric pressure is greater, so notice air is being pushed in to the lungs. Then as we raise the diaphragm, as it relaxes, intraalveolar pressure becomes greater and air is pushed out of the lungs. So this first line right here going above and below atmospheric pressure is the pressure within the lungs, within the alveoli. This lower line is intrapleural pressure. It follows the same kind of sinusoidal pattern of alveolar, but it never becomes greater than atmospheric. So you have a diagram similar to that on your lecture notes that doesn't have the lines drawn in. All right, so here is intraalveolar pressure, and just slightly off, but following the same pattern, we have the intrapleural pressure. And it's always negative than intraalveolar, so it helps to contribute to, remember we talked about surface tension? So the surface tension and the negative pressure both help to contribute to the expansion of the lungs. The hydrogen bonds between the water molecules on the visceral and parietal pleura and sticking to each other help to keep the lungs slightly expanded, and as well as this negative pressure between the lungs and the pleura. So this would be intrapleural pressure here. And it will rise and fall, okay, but it's usually, go back to that previous slide, it's always negative, about between 3 and 4 millimeters of mercury more negative than intraalveolar. So again, even when you're breathing out and intrapleural pressure rises because of the pressure of the diaphragm and the pressure of the thoracic wall, it's still going to be less than atmospheric pressure. And that helps to contribute to the expansion of the lung. Now, what happens if we allow air to get into that pleural space? This can happen a couple of different ways. Okay? There can be a spontaneous rupture of the visceral pleura. Or that spontaneous rupture can be increased by disease, by smoking, by emphysema, or even by asthma. And so let's say that when you breathe out, pressure is increasing. Where is that air going to go? Normally, when you breathe out, air is going to go back out because pressure is greater than atmospheric. But now that it has an escape route, air will also go out into the pleural cavity. Okay? Now you're breathing in. Pressure is greater in the atmosphere, so air is going to flow into the lungs. It's also going to flow into that space. So whether you're breathing in or breathing out, air will enter that pleural cavity. Okay. Yes?
Wouldn't it equalize to where it'd be the same pressure in
Well, as this happens, as air moves into this space, the lung ends up getting smaller. So more pressure, smaller lungs, so you, kind of like the cardiac tamponade that we were talking about, but with air instead of fluid. Okay? Now, if that occurs, especially on the left side, all right, and we start getting a smaller lung, remember what we have on, to a greater majority on the left side than we do on the right? Well, the entire heart itself, all right? So with this getting smaller and this airspace and pressure getting larger, it will shift the heart to the midline. And that's a sign of what's called tension pneumothorax. Just having air in the pleural cavity is pneumothorax. If the pleural cavity is closed and the air can't escape, and especially if it's on the left side, shifting the lung over, then this is known as tension pneumothorax. And like the cardiac tamponade, it affects the ability of the heart to fill with blood. It also compresses the great vessels and affects the ability of the heart to pump blood out. So it causes a decrease in blood pressure and a more rapid heart rate. Yes, Rachel?
What's the difference between those two?
Let me show you. I also have a couple of videos. Pneumothorax just means air in the lung. I mean, air in the pleural cavity. Okay? Let me show a different mechanism by which this can occur.
Sharp objects.
So not only can the visceral pleura rupture just spontaneously or disease, a broken rib. So if we put the body wall out here, and we have our ribs, a rib fracture can tear through, and we still have a closed space. So this can still occur. That rib might tear through the skin, or you might have an open wound. Say someone's not wearing their seatbelt and they get thrown against the steering wheel and it breaks, and so you have an open skin wound, a second chest wound. All right, now with that you would still have pneumothorax. Watch what happens. Pressure decreases as your thoracic cavity increases. Not only is that going to draw air in through the conducting pathways, it's going to draw air in through the open chest wound. Okay? The difference now with the tension pneumothorax, Rachel, is now when you breathe out, air will go into the pleural cavity, but it can also exit the pleural cavity and go out. So what we do is you'll have air leaking out, and you'll have this bubbly bleeding. So if you've got a chest wound that's into the lung tissue or into the pleural cavity space, when you breathe out, you'll have a bubbly bleed, pink tinged, indicating that air is escaping. Okay? So that is not going to cause the tension pneumothorax because air has a mechanism of escaping. So tension pneumothorax requires the air to be trapped. Well, the lung will collapse to some degree with both, but not as much as with the tension. Okay? So,
Professor,
yes.
so now when the rib actually has to puncture, what's the effect with the blood and stuff that's actually going to...
Well, you can also have a pneumothorax or hemothorax. You can have blood filling up.
So we're just under the assumption that there's no blood and
Yeah,
just air.
or more air than blood.
So how are the pressures then?
So with both of them, the pleural cavity is going to be the intrapleural pressure, rather than being negative, is going to be equal to atmospheric pressure or higher than atmospheric pressure when you're breathing out. Okay?
Okay, so interpleural.
So intrapleural pressure, rather than always being lower than intraalveolar and lower than atmospheric pressure, can be equal to alveolar or greater, and equal to atmospheric pressure or greater, depending on the actual respiratory movement. The pleural cavity becomes the alveoli in that sense. If it is a tension pneumothorax, then your pleural pressure is often greater than alveolar. That's what's causing the lung collapse. So let's take a look at an animated video here, and then there's another one that illustrates it using a sheep lung. Yeah.
You have to just sit still for a long time.
The lungs are encased by 2 layers of tissue, similar to a fist that has been pushed into a balloon. The space between the layers, called the pleural cavity, is lubricated so that the lungs can slide comfortably across the chest wall. If air enters the space, it is referred to as a pneumothorax. One type of pneumothorax, called a traumatic pneumothorax, can be caused by an injury to the chest. A blunt or penetrating chest injury can cause a small tear on the surface of the lung, allowing air to enter the pleural cavity and to become trapped. The pocket of air produces excessive pressure on the lung, causing it to collapse. Spontaneous pneumothorax occurs without injury as a result of certain lung diseases, such as asthma, emphysema, or COPD. Small air-filled sacs called blebs can form on the lungs. If the blebs rupture, they can release air into the pleural cavity. Pressure from the trapped air causes the lung to collapse. However, a spontaneous pneumothorax can also develop in a person with no obvious risk factors or disease. This condition is more common in smokers and in men between the ages of 20 and 40. Attention pneumothorax is a serious complication that can develop with any pneumothorax. If the pocket of trapped air cannot escape and continues to grow, the increased pressure in the pleural cavity can push the heart and major blood vessels to the other side of the chest. When this shift takes place, it causes a significant drop in blood pressure. This is a life-threatening condition that requires immediate medical attention.
Okay, now this is going to be demonstrated on a sheep lung with the parietal pleura being represented by a plastic bag.
Prezentujemy, jak pracują zdrowe
They'll be
płuca,
doing some
cały
subtitles here.
proces wentylacji i oddychania.
This is what we're looking at in the lab today.
Jak to wygląda w sytuacji, kiedy mamy
So now the trash bag
sceny, na
represents the
przykład
parietal pleura.
płuca pracują w klatce piersiowej. Okej, drugi preparat został przez nas uszkodzony. Najpierw zaprezentujemy
So this is a dorsal view of the lung. You can see the gaps in the visual pleura.
eksplozji. Tkanka jest uszkodzona i powietrze ucieka. Teraz zaprezentujemy, jak to działa w sytuacji uszkodzenia.
So with every breath, more air is moving into the pleural cavity and then not leaving when they breathe out, because when they breathe out, that's just pushing even more air into the pleural cavity rather than sucking it out.
Teraz po nakłuciu.
So now they're going to cut that parietal pleura. So that would be like that last opening I made. And now you're losing air, but it's also, you're not getting as much air in the alveoli, so you'll still have a partially collapsed lung, but you won't be increasing the volume of the pleural cavity.
Anytime I open the internet.
So you can see that increasing air puts pressure, so it's going to have a higher pressure force than the alveoli do. So with every breath, there's an increased likelihood that less air is expanding, more air is moving to the pleural cavity. That's with the next breath, less air can stay in the alveoli.
So you just want to puncture your skin pretty much.
Yeah, so that's what you do with the chest tube. Okay. The next slide shows the broken ribs. And so if the rib fracture is internal, that is still going to have the same effect. All right, to have that bubbly white froth in the escape with the preventing the pneumothorax, you would have to have a compound fracture where the rib fracture actually broke the skin.
It's not that easy. I've broke 5 ribs and I still haven't punctured my pleural yet.
Well, one of the morning students talked about when he was a teenager, he didn't realize he had a hairline rib fracture. And he reached up to grab some drinks off of a shelf while they were getting gas. And he was in the store. And as he came back, it moved the bones of the fracture. And the pain from that caused a spasmodic reflex of his diaphragm and intercostals and even the bronchioles. And he said everything just shut like that. And he could not take a breath. His muscles spasmed. And his friend took him to the hospital. He was just gasping, just a little like that was all he could get his lungs to expand. And with those shallow gasps, obviously you're not getting much actually into the respiratory parts of the airways. And so when he got to the hospital and his friend explained what had happened, because obviously he couldn't talk, they injected him with massive muscle relaxants so that his diaphragm gave way, if you will, and was able to inhale. Now online is a document of an article about, I actually saw a video news story of this, and I've searched for years, and I had it on VHS, but then it must have gotten taped over with NASCAR racing by my young son at the time. So I was able to find the article about it. But this woman went from the UK, from England, to Singapore for vacation. And she was there for a couple of weeks. And while she was there, she met this guy, and they hung out together. Started or fell completely in love, who knows. And so on the day that she was leaving, she had to go back to work. He offered to take her to the airport, and he took her on his motorcycle. She must not have had much luggage. But if you're going to the tropics, 5 bikinis, and that's all you need. And while they're on their way to the airport, they crashed. And she's bruised and bleeding, but she still has her plane to catch. So she shows up at the airport, covered with dirt and debris and blood, and the flight attendants are like, "Are you sure you want to fly?" And she says, "Yeah, I've got to go." So she gets on the plane, and they take off. Now, planes are pressurized, but not to atmospheric pressure. And flying altitude is usually around 35,000 feet. That's about a little under 7 miles. And she was okay until she reached down to get something out of her bag and felt this sharp pain. And the ribs that she had fractured tore through her pleura. Not her skin, but through her pleura, and she started getting a tension pneumothorax because it happened on the left side. And she started having difficulty breathing and racing heartbeat, and it was a medical emergency. But they were, closer to England by that time than they were to Singapore. So they kept on flying, and the flight attendants asked for any doctors on board. And there were 2. One was an OBGYN and a professor at the local medical school in London, and the other, I think, was an internal medicine guy, but I don't remember. Anyway, they asked for bottles of water, a coat hanger, and I'm not sure, I don't think plastic straws would have worked, but they got some tubing, and they set up a chest tube. So chest tubes work by directing using the pressure of your breathing apparatus to push air out and not allow air back in again. And so when you breathe out, pressure increases in the pleural cavity. The air is directed down into the bottle of water and bubbles up to the surface. And then when you breathe in again, it can't be pulled back in. So and remember, the tension pneumothorax is an emergency because there's no escape for that air. And so they could have just poked a hole in there, but then when she breathed in, she would have pulled more air back in if all they'd done was just tore it open. So they used the coat hanger to poke the hole, probably on this side, in the lower rib area, usually between ribs 9 and 10, and then used the water bottle. They wouldn't have had this stopper, so I'm not quite sure. Straws you would have thought would have collapsed, but so I'm not sure what they used. I don't remember what they used for the tubular part, but set up an emergency type of chest tube structure. Now, in hospital chest tubes, they actually have valves, one-way valves, so that the air will come out, the water will go back up. And there's a series. You can have a single tube, double bottles, 3-bottle system. You don't have to worry about that. I just kind of put it up there because it was interesting And so these are used for either the removal of fluids or from air in a closed situation. Now, in an open situation where the ribs or the external traumatic penetrating instrument creates an external opening and you see the bloody wound bubbling with air when they breathe, that's kind of essentially your chest tube, but you need to modify it. So when they're breathing out, they're getting rid of the air from the pleural cavity, but then they're drawing it back in again. And so it was kind of out of sequence, but that was what this image here was for. And this is another source of extra credit. Okay, 3 points for letting me know that you have in your mode of transportation plastic wrap, such as saran wrap, and adhesive tape, bandage tape, or a form of adhesive tape. And what you want to do is wrap that over the sucking chest wound, as it's called. You don't want to tape completely around it, because you want to use this as they breathe in. It pulls that plastic wrap against the chest wound and stops air from coming in. You want to leave one corner free, so as they breathe out, pushing air out of their pleural cavity, you've got a corner free for that air to escape. And then when they breathe in again, they're not pulling more air in as atmospheric pressure is greater than the pleural pressure it has access to. Okay? So by our lab exam, if you wish to do this, just send me a note, or you can attach a picture. A note is fine. You don't have to take a picture. I'll believe you. That you have this container of saran wrap is a brand name, but any generic plastic wrap that can be placed over, and then the tape to attach it.
Is that common? That's why you...
When people wear seatbelts, it shouldn't occur. But somebody that's riding a bicycle, you know, the cyclists that are out on the side of the road, that can happen. It's typically the ribs going both external, you know, splintering and opening up to the external surface, or a tree branch, you know, piercing that area. It's probably, I've never had anybody write back to me or send me an email. Guess what? I got to use my plastic wrap.
So she just wants us to put that in,
I
have
still
it ready in
tell
case we have an injury.
Okay? So that's this, remember we talked about the surface tension helping to keep the lung expanded, and this negative pressure helps to keep the lung expanded as well. When that intraalveolar pressure becomes positive or equal, higher or equal to atmospheric pressure, that's when we see the lung collapse, okay? Because it overrides the surface tension between the visceral and parietal pleura and the lung. As more air builds up in there, the lung becomes collapsed. All right, now let's look at factors that influence or affect pulmonary ventilation. So pulmonary ventilation itself is the movement of air into and out of the lungs. And again, as with blood flow, that is along a pressure gradient. Unlike blood flow, that pressure gradient changes. So we have air flowing into and out of the same channels. And these are some of the factors that can affect